Ladies and gentlemen, we move on to the next state-of-the-art lecture, Challenges in STEMI Care in India and in the Real World. Along with our chairpersons, may I also invite Professor Dev Pehlajani, Dr. Rabin Chakravarti, Professor P.C. Manoria is very much here with us, Dr. Abdesh Sharma and Dr. Srinivas Kumar. Professor Nanda would continue to join the proceedings. The state-of-the-art lecture features President CSI and the organizing chairman, WCCPCI, Dr. H.K.Chopra for the next 12 minutes. Dr. Chopra.
Good morning, friends, again. Like the person who is behind all these programs, sole pillar, standing along with all the people who are sitting over here. And it was his brainchild 10 years down the line to start these kind of a program in India. And believe my words, we were here almost 10 years down the line in 2006, conducting our first program. This is absolutely non-commercial. None of the program in India is being conducted the way it is being conducted over here. It's spirituality with learning. And for this, we have to have a person of a caliber of Dr. H.K. Chopra, who is going to deliver this prestigious state-of-art lecture, Challenges in STEMI Care in India in the Real World. And I'll call upon all my faculty, chairpersons on a dais, and bestow him with the state-of-art lecture to Dr. H.K. Chopra. And let's give him a big hand for all his contribution to World Congress of Clinical Cardiology and Preventive Cardiology in India. And
please stand up and do a standing ovation to Dr. Chopra, please.
Thank you very much, ladies and gentlemen. With this, we'll start with the proceeding of the session since we are running short of time. The subject given to me is challenge in STEMI care in India and in the real world. I think we all know that the time delay is a real problem. To handle STEMI in India is very difficult. A lot of people, they say we are doing a primary PCI. I am really surprised. Is it really a primary PCI? People are reaching 5 hours or 6 hours. Already so much of damage has taken place. And see, the hospital to home time is usually more than 300 minutes. Though the time required is less than 150 minutes. Door to needle time is delayed. Door to balloon time is delayed. There is no protocol followed in any emergency areas, especially in North India. Molasri is here. I'm sure he's looking at me. We have a lot of issues in a place like Delhi. Due to lack of awareness, lack of interpretation of EKG by general physicians, and poor transport system, and the PCI is possible only in 10% of patients. See this. See the crowd. I'm talking of Delhi. How can a patient reach in time and we'll do primary PCI? It's a real challenging. See the data. It shows very, very poor drug storage, stay out is poor, ambulance care is poor, so much of time wastage. Even when a patient reaches an emergency, for emergency to a cath lab, sometime at night, technician is not there, doctor is not there, and guidelines or guidelines which are mentioned, are they really guidelines for us? There is a huge gap in the guidelines and the clinical practice. Time is highly critical if you really want to reduce the morbidity and mortality, and the mortality with STEMI is almost 9%. Early TNK is the only answer. It can abort MI, can make a larger to a smaller one, transmural to a subendocardial MI, prevent the re-MI and prevent the extension. In the golden hour, the TNK is definitely superior. The golden hour is the key, but what is the golden hour? I think we have to understand. If a patient comes in 0 to 1 hour, the saving rate is 65 per thousand. If it comes in 2 to 3 hours, 26 per thousand. If 3 to 6 hours, it's 27 per thousand. ACC and AHA guidelines have shown very clearly bolus dose of treatment of TNK in STEMI gives better results than infused other agents. The main agenda of my presentation, ladies and gentlemen, to highlight the efficacy and safety of pharmacoinvasive approach. I'm sure you will get a lot of insight from Dr. Molasri after me to assess the clinical successful thrombolysis and to evaluate the morbidity and mortality benefit and hazard ratio. See the registry data. The registry data is shown very clearly in almost 15,000 patients in 722 centers. And it is just a profile that so many were hypertensives and diabetes and smokers and metabolic syndrome. and the time window is very important. The success rate is up to a tune of 96.5% if it is given in first 3 hours, as compared to a delayed treatment where the success rate is as low as 85%. Time is myocardium. It's very important. This should be kept in mind all the time. And the reperfusion rate or the recanalization rate, success is slightly lower beyond 6 hours and is lower in females as compared to males and lower in elderly population. And you see here the data is very clear that the total mortality can be reduced significantly to 1.6%, from 9% to 1.6%, if you are very meticulous and effective in giving early intervention with TNK. See, the mortality and morbidity otherwise in STEMI and non-STEMI is 8.6 and 3.7%, while the re-MI rate is 2.3 to 1.2%, and the stroke rate. The morbidity data has shown very clearly the morbidity produced with the TNK is rather very low. We should not be scared of 0.93% of intracranial hemorrhage and deprive a patient of the benefits up to a tune of 95%. Minor bleeds are easily manageable. Stroke rate is very low and VT is not highly malignant. Concomitant medication were given to these patients is very well mentioned here. And the clinical successful thrombolysis rate, as I mentioned to you, is tune of 96.6%. Italian registry with 27,000 patients have shown very clearly immediate and easily available and everywhere is TNK. And dawn to balloon time in primary PCI usually exceeds 90 minutes in a place like registry mentioned here. Primary PCI does not reduce the mortality consistently. These are not my data. Data has already been published. TNK efficacy is enhanced by adjuvant treatment. The whole data is very clear. If you really want to reduce the ischemic burden, believe in more facilitated PCI rather than primary PCI. Primary PCI is not feasible in a place like India. The reason for preferring thrombolysis is very obvious here. The resolution rate is very fast as compared to primary PCI, and the potentials of reperfusion, as I mentioned to you, how we can reduce the salvage, the jeopardized myocardium and its complication and lower the thrombus burden. You just heard Dr. Pelajani, how we can reduce the burden of thrombus suction and the need for stenting, and even the morbidity and mortality can be reduced. The real success rate or pillars of success in STEMI is a rapid diagnosis, which is usually delayed in our country, and early reperfusion is also delayed. The reasons for using TNK, ACCP guidelines has given very clearly that TNK is class 1A recommendation, and TNK recommendation and pre-hospital thrombolysis protocol by Vienna data, Mayo Clinic data, and French fast MI registry data is very, very clear. Potentials of TNK cannot be overemphasized. As early as 5 seconds, no hypotension, and we see no allergic reactions, and we see the longer half-life, rapid action, high fibrin specificity, and can be given according to the weight, early and easy manageable bleeding, especially in elderly. Let's reduce the dose to half in elderly if you really want to reduce the hemorrhage. And we see here the agent of first choice in pre-hospital thrombolysis is TNK. And the data is very clear. If you compare TNK with streptokinase, the fibrin affinity and fibrin specificity is very, very high, and the bleeding complication is low, and antigenic reaction is hardly any as compared to streptokinase. If you compare to LT place, the bolus administration is feasible with TNK, and we see here the half-life is just 20 minutes as compared to LT place, which is very short, 4 to 6 minutes, and the patency rate is 13 times higher in TNK as compared to LT place. Only 4% of transferred patients received primary PCI within 90 minutes from first medical contact. See the data. The first generation, second generation, and third generation thrombolytic agent is important. Pre-hospital thrombolysis is strongest independent predictor of in-hospital survivors in UK. STEAM trial has shown very clearly that 1 year mortality in STEMI with a pharmacoinvasive approach and primary PCI is identical. It's similar. There is no difference within the first 3 hours of MEI. And a STEMI trial is given very clear idea that all STEMI patients in the real world with primary PCI is not feasible in less 60 minutes. Less than 60 minutes is not feasible. TNK followed by primary PCI in 24 hours is strongly recommended protocol for all the emergency care. And the STEAM data has shown that the cardiac mortality is almost same in the pharmacoinvasive arm as compared to primary PCI. See the data. Only 20% of US hospitals have angioplasty services. What to talk of India? Very difficult. Potentials of pharmacoinvasive approach, as I mentioned to you, golden time, golden window is less than 2 hours. If you really want to prevent the jeopardized myocardium, TNK given less than 60 minutes is highly beneficial to abort MI. It may help reducing the thrombus burden and reduce the mortal time delay of more than 90 minutes, reduce the benefit of primary PCI. If it goes beyond 90 minutes, the benefits are already gone. Then is it really primary PCI? It minimizes the time from chest discomfort to ECG less than 30 minutes, and ECG to drug intervention less than 60 minutes, and drug intervention to PCI should be less than 120 minutes. To conclude, ladies and gentlemen, CST with TNK is highly significant. There is a robust evidence that 96% is the success rate. CST rates lower in elderly, and we have to give a half dose to prevent the complications like a hemorrhage. Overall mortality rate is highly significantly reduced from 9% to 1.6%. Minor bleeds easily manageable. We should not have any fear. Overall morbidity benefit, TNK agent of first choice, no hypertension, no allergic reaction. What's the take-home message? Ladies and gentlemen, health of millions is at stake with a rising menace of STEMI in India. Early TNK administration in STEMI is the need of the hour. TNK is very safe, very effective method of emergency thrombolysis. TNK followed by PCI is the answer. There is no fight, there is no conflict. Time to reflect TNK potential in STEMI is now. Pharmacoinvasive approach is the answer. We should act locally if we really want to impact globally. No fight. TNK versus primary PCI is no fight. Solution is TNK and then PCI. See the data? And I think our pioneers in thrombolysis who are working for last 82 years, till et al. 1933 he started working on thrombolysis, and Professor Cannon who gave an insight to it. Thank you very much for your kind attention.
I would just like to add, Dr. Chopra, with his remarkable and outstanding oration today, told us that he is ahead of his times. Not only is he the soul of the conference and this association in a very soulful environment, he is working on a book which is soon to be released at the prestigious CSI called Update in STEMI. And working on STEMI and releasing a book only far-sighted leaders can do, and Dr. Chopra needs to be congratulated. Thank you.
Thank you. Thank you very much, Chairpersons.
I think we as members of the medical fraternity must realize that the battle of STEMI is won in the hospital. It is the battle outside the hospital which is not tackled at all. Late diagnosis, lack of awareness, and there are so many other parameters which have to be tackled, and all of us must step out of the hospital if we really want to optimize the care of STEMI. I'm sure you enjoyed the flashes of expertise during the discourse of Dr. Chopra.
Thank you. Thank you very much.
I think, Dr. Chopra, you have really pointed out the problems of managing the patients with STEMI with so much of a traffic. I think apart from traffic, even if the patient reaches the hospital, the issues come of the economics. Because if you see, 80% of our patients pay for their own, from their own pocket. Now when a patient lands up in the middle of the night in a hospital, and you say you want to go and take a patient for primary PCI, the next thing the hospital administration asks for is some deposit. At middle of the night to cough out something like 2 to 3 lakhs of rupees, it's not going to be that easy. Whereas a shot of TNK, which may cost 25 to 30,000 rupees, is easy to administer. And therefore one should not lose that precious time, because if you give within first 3 hours, whether you did a primary PCI or you gave TNK, the results are more or less identical.
Thank you. Thank you very much, Chairpersons. We'd like to thank Dr. Chopra for delivering this state-of-the-art lecture.